Next lecture in advanced life support course is post-resuscitation care or post-cardiac arrest care. End of this lecture, participants are expected to understand what is post-cardiac arrest syndrome and the post-cardiac arrest care, which involve ventilation, hemodynamic optimization, and neurological recovery, and know a bit about prognostication. Post-cardiac arrest syndrome is actually a very complex pathophysiological process. Looking at the molecular level, during a cardiac arrest, all the cell has no flow, in which anoxia happens. During the CPR, there's minimal flow when ischemia happens. And during the return of spontaneous circulation, reperfusion happens. And post-cardiac arrest syndrome happens in 100% of the patient who has gone through cardiac arrest, CPR, and return of spontaneous circulation. To be exact, post-cardiac arrest syndrome is equivalent to post-anoxic ischemic reperfusion syndrome. And the main component of this syndrome involve early but severe circulatory dysfunction, which may lead to multi-organ failure and death. So, the pathophysiology involve early stage of myocardial dysfunction. This accounts for most death for the first 3 days. It starts to recover after 2nd to 3rd days post-cardiac arrest. If you get this patient to go through the angiogram, most of them actually has no coronary artery disease. And during this period, anoxic brain injury can happen if you are not careful, because it will be exacerbated by microcirculatory failure, hypo or hypercarbia, pyrexia, hypo or hyperoxemia, hypo or hyperglycemia, or hypotension. Eventually, multi-organ failure and death happen. How severe it is? The clinical features, the intensity actually varies, but roughly it's proportional to the duration of no flow or low flow. Overall outcome depends on underlying cause of collapse, availability of early high-quality CPR, and post-resuscitation care. Therefore, you have to know what are the post-resuscitation care protocol. Number 1, control ventilation. Intubate, ventilate, sedate, plus minus relaxant, because adequate sedation will reduce the oxygen consumption, and the use of muscle relaxant is helpful. With that, ILCO has conducted the research and found out that even with the muscle relaxant use, there's no increased risk of critical illness polyneuropathy. But when you need to use muscle relaxant, have to consider use EEG, because seizures can happen, and seizures will be a bad outcome for the post-cardiac arrest patient. And for this control ventilation, we are aiming normal PaCO2, which is 35 to 45 millimeter mercury, and avoid hyperoxia, titrate FiO2, aim SpO2 94 to 98%. Next protocol involves coronary reperfusion and hemodynamic management. In those due to ST elevation MI, the coronary angiogram should be performed emergency for all these patients with ST elevation. In 2015 guideline also stated that in those patients with no ST elevation, but strongly think that the collapse is due to the MI, means that patient has non-ST elevation MI, early PCI is also recommended. Next protocol involves hemodynamic optimization. This ANCHOR guideline follows ERC guideline, because most studies shows that MAP more than 70 millimeter mercury has a good neurological outcome. If AHA, the MAP more than 65 millimeter mercury. what happened to the neurological recovery? In order to optimize that, we should do adequate cerebral perfusion, targeted temperature management, seizures control, and glucose control. TTM is the next protocol. The adopted term in 2015 as compared to the therapeutic hypothermia in 2010 is because ILCO found out that different patients suit different target temperature. So the recommendations are the comatose adult patients with return of spontaneous circulation after cardiac arrest must have targeted temperature management. And the recommendations is to keep the core body temperature 32 to 36 degrees Celsius for at least 24 hours. And pre-hospital cooling with large volume of cold IV drip is not recommended. Seizures control is another protocol because seizures will increase CMRO2 and worsen the brain injury. But routine prophylaxis anticonvulsant is not recommended. And the last protocol for post-cardiac arrest care protocol is sugar control. It's stated in the ACLS textbook that hyperglycemia is not good for post-cardiac arrest care, but hypoglycemia is more disastrous. So therefore, keep sugar level about 10 millimole per liter and avoid tight sugar control. So, in the case of cardiac arrest with return of spontaneous circulation, post-cardiac arrest syndrome definitely happens, and post-resuscitation care is important. However, prognostication has to be done to determine how much support we need to give to this type of patient, because that is common due to the hypoxic ischemic brain injury. So therefore, active withdrawal or life-sustaining treatment based on prognostication is important. So when to prognosticate? The earliest time for prognostication using inpatient treated with TTM, targeted temperature management, may be 72 hours after return to normothermia. And the earliest time to prognosticate a poor neurological outcome in patient not treated with TTM is 72 hours after cardiac arrest. With that, thank you so much.